Good morning and welcome to the Davies Use Case webinar being presented by Memorial Hermann on the VAP bundle, a story of data-driven process improvement. A use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of health care. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcome resulting from health IT enabled care delivery. So it's my pleasure to welcome our speakers for today's webinar, and I will turn it over to them to introduce themselves.
Hello. Today's topic is the VAP bundle, a story of data-driven process improvement at Memorial Hermann. And before we get started, I just want to explain that VAP stands for ventilator-acquired pneumonia, and that is the abbreviation we will be using throughout the presentation. We've chosen to do a joint presentation today because here at Memorial Hermann, we're very proud of the interdisciplinary nature and the way in which all of our different teams and departments work together, always with better patient care at the center of our concerns. So today there are going to be 3 speakers in the topic. My name is Jennifer Westmoreland. I am the manager of a medical informatics team at Memorial Hermann, and my responsibilities are quality, patient safety, infection control, and clinical decision support as it pertains to the EHR. And now I'd like my colleagues to introduce themselves.
Hello, my name is Tawana McInnes-Cole, and I am the System Director for Infection Prevention at Memorial Hermann. My responsibilities include providing guidance and direction and focus for the global overall infection prevention program as a whole.
And I'm Jocelyn Thomas. I am the Manager of Infection Prevention for the Memorial Hermann system. I'm one of the regional managers here, and I oversee the Central Surveillance Team, and I also oversee the South Region Hospitals infection preventionist.
Bundles, why are they important? And so in order to help us reach the outcomes that we so desired, we had to decide to pull together evidence-based practices in order to be able to address the ventilator-associated pneumonias that we were seeing within our facility. So these bundles are a combination of about 3 to 6 interventions that we found that when we coupled them all together and implemented those interventions on every patient every time, that we would see the outcomes that we were looking for. We obtained our bundles through peer-reviewed literature, and we also wanted to implement use of these bundles through house-wide surveillance, and we took all of that information and decided with careful implementation that we would definitely see process improvement and standardization. So being on the ventilator, of course, is to allow the patient to rest their lungs, and in order to have the ventilator assist in the breathing complications that they may have. But while being on a vent, there are some, indeed, complications that are associated with it. Ventilator-acquired pneumonia is one of those, in addition to what we now know as the ventilator-associated events. And later in the presentation, we'll talk about the difference between the 2 of those. Being on a vent, the patients do have up to a 20% chance of developing pneumonia. Greater than 39% of the pneumonia cases occur in the acute care setting. With ventilator-associated pneumonias, you will see an increase in ventilator days as well as the length of stay for the patient, including increase in antibiotic use. And unfortunately, the mortality may also exceed 10%. Along with pneumonia information, you also have to consider financial impact of what could happen if a patient does acquire a ventilator-associated pneumonia. So knowing that at least 20% of these episodes are preventable, we do see cases upwards to 52,000 plus a year. VAPs also make up approximately 31% of the cost of the top 5 healthcare-associated infections, and the estimated cost in 2013 of a ventilator-acquired pneumonia is $40,000 plus. And having reviewed peer-reviewed literature and journals and having attended conferences, we decided that we absolutely had to do something to ensure that we were providing the safest care for our patients. So we introduced our ventilator-acquired pneumonia bundles. These bundles were implemented for patients that were 18 or older, so specifically our adult population. We divided these bundles into 2 elements, a nursing component as well as a physician component. The nursing component, as you see here, has a requirement of suctioning and oral care at a minimum of every 4 hours. In combination with nursing, respiratory therapy was also a partner with us in these ventures, so they too could help perform the suctioning and oral care for the patient. The physician elements of this particular ventilator-acquired pneumonia bundle consist of the order for the head of the bed to be elevated, the stress ulcer medication to be ordered, the VTE prophylaxis medication or mechanical implemented. And then also if the patient was sedated, we wanted the patient to have a sedation holiday. So in 2006, and coupled with the fact that we live in Houston, we thought it ironic to say, Houston, we have a problem. When we looked at the data in 2006, it showed alarming VAP rates to us. And again, with our peer-reviewed literature and knowing the financial impact and the mortality that's associated with the VAP, we wanted to make sure that we address this immediately. Another steamboat to our efforts in moving forward was also understanding that VAP rates were becoming a focus for CMS. So here VAP rates looked like when we began this journey. And you can see our very first marker where we saw across our system that we did have a VAP rate of 6. And as you can see with our control chart, that there really wasn't a consistent or stable process in place. We did see some elements where the process of the ventilator-associated pneumonia rate did go down, but then there were opportunities where it would go right back up again. That showed to us that there was some inconsistencies in practice, and we had to implement these bundles in order to get a standardization of our outcomes. We implemented the VAP bundle. So we pulled together an interdisciplinary team led by infection prevention. Again, we took information from IHI, and we also decided that once we implement these bundles and we got them standardized, that we also had to monitor the practices that our nurses and our respiratory therapists had in place. We put all of these together in one big global bucket, and we called that bucket Do No Harm. Of our implementation of the VAP bundle. So in 2007, once we got it standardized and implemented and everyone understood what both elements were, the nursing bundle and the MD bundle of the nursing elements and the MD elements of the bundle, once we got that hardwired and each of our nurses understood what was expected of them, in May of 2007 where our monitoring came into place. So we implemented that monitoring via a paper-based checklist that our infection preventionists were responsible for. Then in 2008 to 2009, we were able to convert that checklist to our electronic health record. In March of 2010, we were able to electronically abstract that compliance that our nursing staff and respiratory staff were documenting. And then in 2013, the CDC changes the criteria from ventilator-acquired pneumonia to ventilator-associated events. Also in 2013, internally, Memorial Hermann developed a ventilator-associated event report that assisted us with identifying these VAEs. In 2016, we saw that we needed to do a VAP bundle upgrade. In 2017, Memorial Hermann went on the venture of adopting and introducing and using the Theradoc module for infection control. In July of 2017, because we repeatedly monitored our progress and was always on top of how we could improve, we saw another need to upgrade our VAP bundle. And each of these timelines will be discussed later in the presentation. So our infection preventionists, again, had the responsibility of, once this VAP bundle, the MD elements and the nursing elements were introduced, the infection preventionists had the responsibility of monitoring to make sure that each of the expectations of the bundle were indeed implemented. And so with the help of our multidisciplinary task force, where all of our hospitals were represented, the design session of how we wanted this to actually work occurred. We also standardized definitions of each of the elements so that everyone was on the same page. We had the expectation that our ICUs would maintain these policies and procedures with all of their staff. Communication and education was imperative, and then to ensure that these processes stuck and would be sustainable and maintained throughout the years to come, our system decided that a performance incentive would also benefit us. That the infection preventionists used in order to ensure that both the nursing bundle elements and the physician bundle elements were implemented. We were able to pull data from that checklist and enter it into a database that we use called MIDAS. From that MIDAS database, you will see that we were able to provide bundle compliance. So each element of the MD bundle and the nursing bundle, we were able to provide a compliance rate for all of them. And then additionally, our thought process with this implementation is that not only would we see an increase in compliance with the bundle elements, we would also see the desired outcomes that we were looking for in the VAP rate. These rates and the compliance were both reported at a system level as well as at the nursing unit level in each of the hospitals. Of what our data analysis and what the ventilator-acquired pneumonia bundle actually looks like. So again, as I mentioned, each element receives its own compliance rate. So what's the head of the bed of? What was the compliance percentage associated with that? Was there stress ulcer medication ordered for the patients? What was the compliance rate associated with that? So on and so forth for DVT prophylaxis, for sedation weaning trials, and then for the oral care and suctioning expectation of the nursing bundle. Again, each month, every element got its own compliance rate, and we were able to see those system-wide as well as in the nursing unit. We talked about that there were some opportunities where we saw that we had a VAP rate of, at some points, as high as 6, and maybe even some as high as approximately 6.2, 6.3. But you can see here where our red arrow marker is. That is where we begin our bundle implementation, the monitoring, the standardization, the auditing, and making sure that the nurses understood what the expectation of them was. To tell you see the downward trend of our VAP rate. So our marker, again, shows where our implementation occurred, and then the happy moment where we saw the clinical outcomes that we were looking for. The VAP rate was finally decreasing.
And now we're going to be talking about some of the technology advances that were occurring at this time that really helped us with electronic documentation, the entering of data into the electronic health record, and how that enabled us to start abstracting data in order to see better what trends we had in a large system like Memorial Hermann has. So starting in 2008 and ending in 2009, we had a rolling series of conversions where our facilities all moved to the electronic health record, and our system is a Cerner system. As anyone who's ever been involved in implementations, either from one record to another or from paper to the EHR, it is a challenging process with many change control barriers and benefits. And so, of course, we sometimes feel that the EHR has been done to our clinicians rather than done with them. And we tried very, very hard to work collaboratively with our clinicians to make sure that the health record represented the best possible practice in patient care, what needed to be documented at the appropriate time, and that the electronic health record provided the information to the clinician at the point of care that could help them make the best possible decision and include all of the many complicated elements of modern patient care. So as the facility is converted to EHR, what did this mean for the VAP bundle? This meant at the time that daily reports were being manually processed and emailed out to nursing, and that the monthly facility compliance metrics were starting to be published in an accessible online venue where all of the staff could see them. Monthly metrics were being reported to system executives as well. But for the first time, we had data in an electronic format instead of people having to have to go in and manually look at paper, write it down, then maybe put it in an Excel document or a MITRE database. We now had a much more efficient way of getting data to be mined. And here's an example of the very first Power Form that enabled the nurses to do their documentation in the EHR. We do have several places where nurses can document the same information, but this Power Form was attached to all of our orders and tasks for the VAP bundle so that the nurses could document everything at the same time in the same place. And as mentioned earlier, many of these requirements are an absolute minimum of once the 4 hours, and many of these elements are actually performed bedside and documented every 1 or 2 hours. 4 hours is our minimum standard of care. So you can see here that this form identifies the patient and then enables the nurse to document what kind of mechanical prophylaxis that the patient is wearing, if any, and what medications they're on. If they're not on medications, there are now reasons to say this patient is not on a medication for whatever the reason. The exception reasons are listed here. So the first time we were really able to document why an element of the bundle was not being carried out. And usually this is by physician order, and there's very good reasons that are standardized, evidence-based for this care to be customized for each patient. As well as having data able to be entered into the EHR, there was a lot of automation happening behind the scenes that started being entered at the same time. And we have a number of rules that operate seamlessly in the background to make the documentation and ordering of the patient care more efficient. So for our adult VAP bundle, we actually have 6 rules that operate behind the scenes. And these rules do things like ensuring when a physician orders that an adult patient goes on mechanical ventilation, the system will automatically order for nursing all of the elements of the VAP bundle. The system will automatically order the sedation holiday. It will order that the patient education be given. So the rule behind the scenes helps us transition from a single quick order from the physician to tasks that go to nursing and tasks that go to respiratory therapists to make sure that all of the elements of the patient care are performed and that there is a timely reminder in the system for the nurse or the respiratory therapist to document that those elements of care occurred and when they occurred. And if they didn't occur, what was the reason why not? The other rules are fairly complex, but what they basically do is they mean that if, for example, suction was ordered and the patient did not have the other elements of the bundle ordered, the rules would make sure that the whole bundle was ordered. So it looks intelligently to see, did I only order one component of this care? Oh, okay, let's order all of the other components so that the provider doesn't have to do that. It also checks to make sure that a patient can only ever have one ventilation order at the same time. We don't like having duplicate orders in the system because we have to have a clarity of decision-making for all care providers to follow. And other rules make sure that if the provider goes in and modifies the order or even cancels it, that a notification is sent to the respiratory therapist and to the nurse, and that the system cancels all of the dependent orders in the system. So these rules operating behind the scenes are also another example of how technology can automate and streamline processes and take some of the documentation burden away from our clinicians so that they can focus more on what they're there to do, which is take care of the patient. So in March 2010, something very exciting happened. The electronic abstraction of the data that was entered in the forms previously shown to you. And here is a copy of the VAP monthly reports that were sent out at the time. So although data was collected on a daily basis and sent out, the monthly report is what was sent out to help the nursing leadership, respiratory leadership, and physicians understand what their compliance rates were, all in the context of having bundle compliance help drive better outcomes. That is the whole purpose, as we mentioned earlier in the presentation. Bundle compliance drives better clinical outcomes for our patient, and that is always our primary driving goal. So as you can see, as well as patient demographics here, we can see the elements of the bundle on the second line. Was the head of bed up 30 degrees, yes or no? Was oral hygiene there and suction? And in order to be compliant on the report, you have to have completed every 4-hour or 24-hour period. If you miss even one period, you're not compliant, and that patient's chart would have been investigated. Nurses would have gone bedside and understood why is that patient not getting or not having documented the appropriate care. So this data is taken extremely seriously. It is always helping to drive excellence in practice.
So in the world of infection prevention, in order to monitor outcomes based on the bundles that were implemented, we have surveillance definitions that are brought forth by NHS and CDC. So in 2013, they changed their definition from VAP to VAE. Earlier, Tawana told you about VAE, which means ventilator-associated events. So the ventilator-associated events is really a definition that looks at multiple preventable events that are related to mechanical ventilation, and is broken up into 4 tiers, and that is the ventilator-associated condition, which is a broad range of any kind of condition that can happen, infection-related ventilator-associated complications, which is called an IVAC, and then you have your possible and probable VAPs, and those now have been combined. Now, with the introduction of the new VAE, we had issues with bringing all of this information to the infection preventionist fingertip because they had to do a lot of chart searching. And we needed the assistance of technology in order to be able to conduct the new VAE surveillance. So we partnered with our medical informatics team, and they were able to build a report that brought all of the information that we needed in order to conduct the surveillance. It looked at the PEEP values, the FiO2, all of the microbiology, antibiotics, all of the information was brought in. And just a quick story about how technology was able to play a great role in the introduction with VAE. Once we introduced this report, which I'll show you an example of on the next slide, once we introduced this report at one of our hospitals, we immediately saw a spike in our VAC, in our VACs and IVACs, and we were wondering what's happening, what's going on. We were able to take this report, take the surveillance that we were doing, introduce it to our critical care committees. They were then able to partner with the respiratory therapists, and they found out there were multiple people changing the vent settings on the patient. So they got together and they were able to bring up a protocol where they collaborated on the care of the patient, making sure that the patients are stable, making sure that everyone understood how to then care for the patient with even moving up and down the PEEP and FiO2 settings. So this is really just an example of that report. As you can see, again, it gives you the clinical event, the day that the patient was placed on event, the minimum in PEEP and FiO2 is brought into the report along with that temperature. This is really a technical thing. It brings you away from the old VAP definition where one is expected to read a chest x-ray. But all of the information is brought into your fingertip, and it makes it more objective when you're making a decision about if a patient has a ventilator-associated event.
So we come forward to 2016, and that is when we started looking at the VAP bundle as it was, the current state, and we did an analysis to see did we need to do an upgrade, and we decided that we did. We're always in a process of constant improvement and surveillance. That is fundamental to quality patient safety operations. So why did we need to do the VAP bundle upgrade? Firstly, and probably most importantly, we were not at absolute zero for VAPs and VAEs. We had extended periods, sometimes years in a row, where there were no VAPs, but we were not at zero, and we always want to aim to zero, being a high reliability organization. But despite this, our compliance rates were high. The compliance rates returned from the data in the report and the extraction said that our compliance bundle percentages were high. So how could this be? And is there any opportunity to improve? So we reviewed new evidence in the literature. Well, that's actually an ongoing process. I wouldn't say we did it just for this, but we made a very targeted effort to see what was going on. And one of the things we discovered that over time, in a mature CPOE system like us, you get documentation drift. Somebody makes a small change here, somebody makes a small change there. The report may be adjusted. Change control is very complex in an extremely large organization, and over time you will get a drift in documentation that may take it a little bit away from the original intense focus, and you can also get a drift in the reporting of that. Sometimes a gap can occur over time. New medications were constantly being introduced, and we needed to make sure that we had a robust change control process to always keep our medication list updated. The problem wasn't that the patients weren't getting the medication as they were, but we needed to make sure that we captured that electronically in our report. It wasn't an issue of patient care, it was capturing the patient care that we were really addressing. Another thing we found is that there are ways to order a mechanical ventilation order that's not as part of an order set. And this opens up an opportunity to lead to a fallout in care. So, for example, you may be ordering all of the elements of mechanical ventilation, but you also need to order chlorhexidine mouthwash. And it was technically possible in the system to have one without the other. So we wanted to make sure that all of our order sets were updated and bundled together as well. We found that mechanical ventilation order set use was fairly low, and when we went back and looked, as our order sets, or medical power plans as they're called in CERNA, we found that the ones taking care of the ventilated patients were not fully aligned with the VAP bundle because they had been developed sometimes at separate time periods and by different groups of people. And although we really try and have full communication in a complex system, it's very challenging to do that. And we also found that of the half dozen or so medical power plans we had, their content was different too because it had been tailored for specialty groups and by specialty requests over time. So how did we implement the second major upgrade to the VAP bundle as opposed to the ongoing smaller changes that have been occurring, very constantly throughout these years? So it's always people, process, and technology. So we created a task force. We called it the VAP Bundle Work Group, and it was sponsored at the system-wide level by our HAI, Hospital-Acquired Infection Steering Committee. And this group was, again, a multidisciplinary group because that is the way we always do everything. So it consisted of respiratory therapists, nursing leadership, infection control, quality, medical informatics, and report writing. What was the process that we did? We had weekly meetings. We consulted our clinical stakeholders constantly throughout this process, from our pulmonologists to our IC nurses to our IPs who were rounding on the floor and taking care of the patients. We held design sessions. We have a complex approval process at Memorial Hermann because of the size of it, but we followed that and got all of the approvals, went to talk to the stakeholders and presented options, got feedback. We did gallery walks. We did all of the process improvement that we could think of to try and make sure that we had the appropriate clinical stakeholder buy-in. And then we went through testing and validation. We then communicated and educated out to the system, and we piloted at one of our ICUs, and we went live with the full upgrade in July of 2017. So what are some of the ways in which new technology from 2006 to 2017 had enabled changes? Well, for one thing, online research had now become extremely easy. All of our meetings were held by WebExes or webinars. Our training and education was also often done remotely as well as in person. And we were able to do extensive data analysis because we now had years of documentation that we could do a really intensive data mining effort on. So this use of data really helped us drive our decisions. We didn't have that before when we did our first major upgrade. The first one, there was nothing, and then we had data from paper, but now we have a mature system with many, many elements to capture. So we did a full gap analysis with all of the documentation elements that we had, and we compared it with our peer-reviewed research to see, are we up to date on everything? What are we capturing? Are there any elements that we can't? We wrote many, many custom reports to pull the data that was we wanted to abstract from this, and we analyzed all of our responses. How many times is a particular response or piece of documentation being entered? Is the content appropriate? Are we still in alignment with the bundle elements? And all of this was continuously reported to the councils and clinicians and people on the floor as well for their feedback and review and thoughts. And we used this constantly so that our decision-making was based on the use of data. Nothing was subjective. It was all very objective, very data-driven with facts to back it up. Here's an example of some of the data analysis that we were doing. The power form that I showed you earlier on, that we first implemented many years ago, we looked at things as simple as how many times was this power form signed. So across our system in 1 month, nursing completed and signed that power form a little over 20,000 times for 841 patient encounters. So when documentation is as intensive as this, it's really important that we make it accurate, streamlined, and aligned with the care that we wish to deliver. Here's another example of some of the data mining that we did. This is just an example for what we used to call peptic ulcer, but now called stress ulcer prophylaxis. And we looked at the documentation. So had the nurses previously been documenting that the medications were being administered, and if not, what were the reasons? So we actually went through and pulled our data and counted how many times each single element was being documented. And the reason to do this is to see not only if we're on track, but what do we need to customize, change, remove. We also looked at many, many places of free text responses. There are often a lot of opportunities for nursing to document in a personalized response, and you can see here some examples. So this is a list, this is a small number of the reasons that a patient was not having internal compression device or an SCD applied. And by pulling all of the individual responses, we could see trends and patterns. For example, often the nurse was having to write that the patient was on heparin and that's why they won't have an SCD. So we knew that this is something it may be worth having as discrete data in the field. We looked at everything from the most common documentations to the one-off outliers. Favorite one that we found, and this was only one time across many, many thousands, was that the reason for not doing the SCD was that Betty said not to. So what happens when different technologies combine? As an electronically based health record matures, you start to get different systems, different applications, different components, and they come from different sources. And the question is, are they aligned or not? We had our VAP bundle, which we developed in-house. But we also had a new technology around. It was called the VTE Advisors. It also started a little bit after the VAP bundle. What are they? What is the VTE Advisor and why did it matter? It is a Cerner-created clinical decision support tool which is only used by physicians and providers. Nursing and respiratory therapists are not able to see it. They don't use it. What it does is it helps the provider calculate the risk of an individual patient having a venous thrombotic event. And it also provides a seamless and easy way for the provider to order the appropriate medication to prevent that or the appropriate mechanical prophylaxis. So you can already see that there are some opportunities for alignment or possibility of conflict because the VAP bundle also contains mechanical and pharmaceutical prophylaxis elements. And so this had led over time to some confusion because there was overlapping content, different indications, different contraindications, and different clinical end users. Here's an example of what the VTE Advisor looks at. You can see it looks very different, but it still is, as I said, a way for the provider to evaluate the patient risk and to provide the appropriate care. So when we went into it and analyzed it, we could see some examples here of how just exception reasons. Why is a patient not on medications to prevent a DVT or VTE? The VTE Advisor here on the column on the left, you can see there's around 9 reasons, and the VAP bundle, the nursing documentation, is a significantly larger list of reasons, and there's some overlap, but the terminology is different, and some are different as well. So we decided that they really should be aligned, and that we would have everything aligned with fundamentally what the VTE Advisor and the physicians were using.
So in January of 2017, Theradoc was introduced to the infection prevention program. And as we talked about earlier, with the introduction of the VAE definition from NHSN, we were still documenting a lot of this in MIDAS and Excel sheets, but we weren't really able to document the detail to the point that allowed us to kind of combine everything into a full-on report or to look at specific details. We had to do a lot of summaries that had to be read and brought together. So with the introduction of Theradoc, this allowed us to actually, with that objective definition, to document exactly what met the definition in an organized fashion. With Theradoc coming in, we were actually able to send these reports directly to the unit so they can see, hey, your patient met for the VAC, the IVAC, and the PVAP based on these specific criteria. And they didn't have to read a full-on summary in order to do so.
So moving forward to July 2017, that's when our VAP bundle upgrade was implemented, but we just wanted to understand that there are always concurrent implementations happening, as Jocelyn just mentioned, with the Theradoc implementation. So what are the highlights from upgrading the bundle? We had a significantly increased accuracy of compliance data. We were able to address that documentation drift and data drift that I mentioned earlier. We updated the order sets and integrated them with the VAP bundle. This was probably the smallest and easiest part of the process, but it was still a very important one. And we took away the single order for mechanical ventilation for adults, which meant that providers had to use order sets. And this decreases any opportunity to have a missing component of VAP bundle care ordered. Another thing that was really important is that we automated communication flowing from the provider to the nurse. That had not previously been there. We had somewhat siloed documentation, and unless the provider and the nurse were actually in communication, the nurse, who is constantly in that chart, maybe once every hour, every 2 hours, or with the RT, that partnership has now become more seamless because we let the nurse see what the provider had documented for the first time. And as mentioned before, we made sure that the VAP bundle, which we could customize, was integrated with the VT advisor so that the same terminology, language, and elements were being entered and captured and abstracted. Did we have any effect on efficiency? We sure did. If you remember the nursing power form that I showed you, that it was documented and signed at least 20,000 times each month, we made a 69% reduction in the amount of times the nurse had to click through that form. And that's just one form, the prophylaxis form. So previously we're averaging about 1.3 million clicks a month in order to move through the documentation. It's now down to a little over 400,000. As I said, nearly a 70% reduction. We automated the display of medication orders and administration. And since we implemented the bundle, we have not had any cases where a patient has been on mechanical ventilation without having appropriate CHG mouthwash orders. So here's an example of what the new form looks like, and at casual glance it looks fairly similar. But when we look a little bit more closely, you can see these boxes here. These display automatically each time the nurse opens the form, and you can see what medication orders were entered by the provider, for example, through the VTE advisor, which is usually completed before the VAP bundle documentation occurs. We seamlessly and automatically show all the relevant administrations that were given today and yesterday. If the provider has entered any reason why the patient should not be receiving a particular medication, instead of the nurse having to document, 6+ times a day, now the information is stored in the chart seamlessly. The nurse can view it, and the nurse is no longer having to have the burden of documenting exception reasons on behalf of providers. And here are some more that show. And if the nurse still wants to add additional nursing reasons why a particular medication is not appropriate, for example, maybe there is a current bleeding that has just occurred, they can do this here too. So this is examples of how we automated the information flow and took away a lot of the burden for documenting data that was already in the chart but not accessible to that particular end user. We also increased, as I mentioned, the use of the ventilation order sets. You can see at the red arrow in July, we implemented our bundle in the middle of July. That's why we have hybrid data. And then from August and September, and in fact to this day, we have a similar order set use of close to 800 order sets a month, and it is 100% equal to the number of patients on mechanical ventilation. There's no way around it. We made our providers use the order sets, and it has really helped with the care. We continue to track VAP bundle compliance. A report goes out every day to the nursing units, and it's now starting to go to the respiratory therapist as well. And it shows all of the care in the last 72 hours for each patient on mechanical ventilation, and particularly highlights if there was any element missing. And we use this to track and continually improve. As I said, documentation and patient care is dynamic, and we have to keep surveillance on that. And the real data that we show is actually not only color-coded in 4 different colors, but also shows the specific percentages for each element of the VAP bundle, shows the overall compliance, and also breaks it down by facility or system total. And this data is still taken very seriously. Our nursing leadership will look at this report, and on a daily level, if they have a question or they have a chart audit, they will reach out and ask. We have very active, proactive nursing, respiratory, and infection control leadership and quality as well. They're all engaged in the same effort here. One of the things that we noticed is that accuracy of the data had increased. I'd mentioned before that our compliance rates were high, but we weren't at 0 clinical outcomes. And we discovered that suction had a little bit of a bigger gap in the data than we'd realized, and so suction compliance wasn't quite as high as we thought. So we took this data back to our clinicians, and we discovered by doing further data mining that there were some opportunities to improve, because we wanted always to be 100% perfect. So, for example, in the periods after shift change, we were able to identify that that is when it is the hardest to make sure that the coordination of care occurs as expected. So looking at this data and having new accurate parameters has really enabled us to go back and have better care at the bedside. So important to have the data accurate, reliable, and constantly being updated. So we're excited that we think that we have identified a few opportunities that we weren't aware of before, and that the data can help us really get to that target of 0 VAPs, 0 VAEs. Optimization never ends, as we are using our data to determine whether or not SUD prophylaxis, which has become an increasingly controversial issue in the literature and in healthcare practice, whether or not that should be considered part of the compliance bundle moving forward. We want to add our tidal volume data to the daily report. We're working on creating interactive compliance dashboards using Tableau, which will give our end users the ability to drill down into detail very quickly and see, rather than just a static percentage outcome or doing daily audits, they'll be able to see dynamic patterns, clusters, events much more easily. And in the future, we plan to move further ahead with Theradoc and implement VAE surveillance modules as well. So overall, our journey has resulted in a decade of VAP bundle partnership. How did our VAP rate do? We have maintained our VAP rate at a new, very low level, and the difference from when we started 10, nearly 11 years ago is represented here. Our journey to high reliability never ends. Dr. Michael Shabbat brought 0 events, high reliability, to Memorial Hermann around about the time that all of this was occurring, and we have awards in the system that are required whenever somebody has 12 consecutive months without a specific event. And we have 23 certified 0 awards for VAP. That means that there are 23 occasions on which a facility has not had any VAPs for a 12-month consecutive period. And you can see here an example at TIA Memorial Hermann, one of their awards where for 4 years they had 0 VAPs. It's an astonishing result for a very major, important hospital. We are very proud of our hospitals for doing this, and we want to keep moving in this direction. How about financial impact? Tawana earlier referred to some of the financial impact. What if we had done nothing? What if we had never implemented a VAP bundle? What if we'd never gone to electronic abstraction? What if we just left things as the way they were? Well, with our hospital expansion over the decade, there have been more ventilated days. We estimate that there would have been, had we done nothing, an extra 1,200 VAP infections. At the 4 or 5-year-old data of $40,000 per infection, we estimate that that would have saved over 100 lives with the previously predicted mortality and over $48 million. 100 lives, $48 million. Our VAP bundle was definitely worth doing. What lessons have we learned from the VAP bundle? We've learned that it's important to keep and maintain a governance structure. You never implement something, congratulate yourself on the success, and move away. It is a process of constant surveillance and improvement. We always have to have multidisciplinary groups at multi-levels, not just leadership, not just bedside care. Everybody has to be involved. Everyone is a stakeholder in having the best possible patient care and in aiming for absolute excellence in patient safety. You have to schedule reviews and updates, for example, to keep up with medication changes. You have to have clinical champions to spread the word. You always have to understand your data, and you have to validate your data. We have a very rigorous process of validating every piece of data that we use on a report, and I cannot tell you how many charts we audited. Even bedside audits as well have to be done to make sure that the data is accurate. Overall, we've learned that automation can help us decrease infections, but with the challenges that come along with EHRs also come great benefits, and being able to mine the data and look and see for trends helps us identify opportunities to improve. And partnership is always the building block of change. What are the key partnerships for the VAP bundle? So at the center, we have our patient who's being ventilated, who needs respiratory support. We want to make sure that that patient has the best possible outcome. So we have bedside, we have our physicians, we have our respiratory therapists, we have our nursing, we have infection control bedside, we have quality and infection control and medical informatics all pulling the data. But those are only just some of the partnerships, because in an EHR system, and in fact in hospital operations, there are so many other teams that keep the lights on, whether it's keeping the servers running, the wireless system, the hardware running, making sure that the power, everything. It is all incredibly important. And so it takes a village, and in a big system, there are many, many components, and I would like to very sincerely thank everybody who works behind the scenes, not just necessarily in front of the scenes, that has made this VAP bundle care possible throughout the years. So overall, what is the moral of our VAP story? The moral is that the price of excellence is eternal vigilance. And so from Tawana, Jocelyn, and myself today, we would like to say thank you for listening.
Thank you, Jennifer and Jocelyn and Tawana for that great presentation. Before we close out, I just want to remind folks where to find this recording among other Davies use cases that they can listen to, and also where to find information on how to apply for Davies. And that information can be found at the HIMSS Davies Award website at hims.org/Davies. And thanks again.